Okay, there we go. So, Kevin, let's say a bit about Kevin. So, Kevin completed his PhD in psychology at West Virginia University, and then he went on to do postdocs at the University of Virginia. Now, brilliantly, he skipped the pond, and for 7 years, consequently, he worked in the NHS and in academia in the UK, with us for some of that time. So Kevin then went back and worked at the University of New Mexico, but most recently, he's been appointed to his current post in 2019, which is Professor of Clinical Health Psychology at Queen's University Belfast. So anybody who here is in the know will have seen and read many of Kevin's publications. For those of you that haven't, there's more than 100 publications on the assessment and treatment of people with chronic pain. And his recent interests have focused around the topics of this talk, which is looking at opioid use and alcohol use in people with chronic pain, and when those are problematic and unproblematic. So absolute pleasure to have Professor Vowles here speaking, and I will hand over to Kevin right now.
Jeremy, thank you so much, both for that kind introduction and to you and the rest of the group at the Bath Center for Pain Services for the invitation. It's nice to see all of you virtually this evening, and I'm really grateful for the chance to be here. As Jeremy just alluded to, I'm a US trained clinical psychologist, but my first job was in Bath at the Center for Pain Services, which was called the Pain Management Unit back in those days. And I have fantastic memories of attending talks in what used to be, where the service used to be at the Mineral Water Hospital in the middle of Bath on Upper Borough Walls in that gorgeous chapel at the back of the hospital. So I know that we're not in that chapel right now. And in fact, the service isn't there anymore. But if it's all right with you, I'm just going to pretend that we're all there in that glorious hallowed ground of science where I saw many of my personal heroes give these talks. So with that preamble out of the way, I'm going to talk a bit today about the use of opioids in the treatment of chronic pain. And I'm going to organize this talk around three main parts. The first part is just to provide a bit of context. Sorry, my slides aren't advancing here on time. The first part is just to provide a bit of context for this discussion on where we find ourselves these days in the use of opioids more broadly, as well as specifically in the treatment of chronic pain. I'm also going to spend some time discussing the scope of the problem of opioid use in chronic pain, because those of us who work in this area will know that even though there is a lot of information out there on opioid prescribing practices over the past 2 decades or so, not all of that information is specific to the treatment of individuals with chronic pain who are prescribed opioids as part of their treatment regimen. So I want to take a bit of time to carefully talk about that. And then towards the latter third of this talk, I'm going to provide to you some preliminary findings from a feasibility study that we completed a few years ago, as well as some information on a currently ongoing trial, wherein we sought to perform an integrated treatment that simultaneously addressed both chronic pain-related interference with functioning, as well as hazardous opioid use. So, for those of you who are in my age bracket, or maybe a little bit older, which is to say late 40s, you will remember a time when opioid use in the treatment of chronic pain was fairly rare. And we as a field have been through use of opioids, non-use of opioids several times throughout our history. There's a well-known psychologist by the name of Bob Kearns who has done a lot of work in the US Veterans Healthcare Administration system. And Bob often makes the jokes that he remembers when opioids were bad and then became good and now they're bad again, that this is a cycle we seem to follow. So prior to the early 80s, opioid use in the treatment of chronic pain was fairly rare and was generally restricted for individuals who had undergone significant invasive surgery, for use at end of life. And when opioids were prescribed, they were generally prescribed at low doses for a time-limited duration and under closely controlled circumstances. And around that period of time, late 70s, early 80s, a group of individuals, clinical scientists in the area of cancer care treatment, began to make some very persuasive arguments with regard to the use of opioids in the treatment of cancer-related pain. They noted that cancer is often associated with significant discomfort and pain, that there is significant distress that often accompanies this, and that the suffering that occurs at the end of life when one has cancer is in some ways needless, as there is a treatment technology available in the form of opioids that could do something about this suffering. And in essence, this was an argument that was intended to decrease opioid prescribing practices for individuals with advanced cancer. If you've ever worked in palliative care, you'll know that this is one of the pillars upon which the palliative care movement was originally based, the aggressive treatment of pain, principally using opioids. Around that same period of time, early 80s to the mid 80s, similar arguments were made, this time by individuals who worked in the area of chronic pain. They noted that the experience of chronic pain is associated with significant discomfort, that discomfort was associated with significant distress, and that some of the suffering was needless. And the arguments went along the lines of the treatment via opioids allowed substantial potential to reduce the unnecessary suffering in those who had chronic pain. At the time, for a variety of reasons that we don't necessarily need to get into today, the argument was also made that if people have real pain, issues of addiction are irrelevant. And that is something, of course, that time has shown us is not necessarily true. So those arguments made in chronic pain were based on a number of papers that were coming out that principally were based on poor quality evidence, things like case series and things like retrospective chart reviews. These papers that came out in the early to mid 80s principally examined opioid use in individuals with chronic pain. And again, the data quality was fairly low. And so two primary examples are here on your screen before you now. The first, by Porter and Jick, which was published in the New England Journal of Medicine in 1980, was a letter to the editor that described a retrospective chart review of inpatient opioid prescription. Porter and Jick in this study found that rates of opioid addiction, as they called it, seem to occur in less than 3% of individuals. But of course, the context here was that these were generally low doses, under tightly controlled circumstances, and usually did not extend beyond the inpatient period for very long. However, again, for those of you who are in my age group, you may remember a time when one of the rallying calls around decreasing prescribing barriers for opioids was Porter and Jick, less than 3%, Porter and Jick, less than 3%. This was one of the primary arguments used to decrease opioid prescribing barriers, and it was based on a retrospective chart review. A case series published in the journal Pain in 1986 by Portney and Foley expanded upon these data and noted that in a small sample of about 32 individuals with chronic pain who had been on opioids for longer than 7 years, there was adequate pain relief, that the dose of opioids did not systematically increase over time, and that the incidence of hazardous opioid use was fairly small. And in fact, across this sample of 32 or 34 individuals, the authors noted that they only saw evidence of opioid addiction in 2 individuals, and both of those individuals had a history of substance abuse or a substance use disorder. So the reason that I describe these data is that there is no problem with publishing poor quality data. Of course, I've published plenty of poor quality data in my life. That's not the problem. The problem is that the way that these data were then used was not in keeping with their poor quality nature. And in fact, what I note here is that this low quality evidence was in effect taken as gospel truth when it came to prescribing practices and clinical practices in the developed countries of the world. In essence, it was treated as meta-analytic truth, which in the scientific world is our equivalent of gospel truth. So if you follow this argument that I've laid out here before you, which I think is reasonably fair to our history, then I would argue there are at least 2 significant consequences of this state of affairs. And the first is an absolute exponential explosion of opioid prescribing practices in the developed countries of the world. Now, much has been made about the so-called opioid epidemic or opioid crisis in my home country of the United States, and that is true. So I'll show you a little bit of US data here just as to illustrate this fact. These are data that Noreen Volkow, who is the head of the National Institutes of Drug Abuse, presented to Congress in 2014. Describing to Congress the 300% increase in opioid dispensation from pharmacies in the years between 1991 and 2012. And that's what's represented here by the blue bars in front of you. She also described the increase in prescriptions for two specific opioid formulations, hydrocodone and oxycodone, each of which also increased by approximately 300%, like 1991 to 2012. Now, these are some older data, so it is important for us to track what happens over time. These still are US data tracking prescribing from 2006 to 2016. These are CDC data. And what you can see is that opioid prescribing reached its peak in the US in 2012 and then decreased over time, such that by 2016, prescribing levels were back at the 2006 rate. But it is important for us to remember where we started in 1991. So in the US, as of 2016, we still were prescribing approximately 300%. We were still prescribing approximately 300% more opioids per year than we were in the 20 years previously. But over here in Europe, we ask ourselves questions like this. Is this a problem that is constrained to the United States of America only? Do we have these kinds of problems here in the UK and over here in Europe? And certainly the problem has been most discussed and most prevalent in the US. So some fairly recent papers that came out are worth me highlighting today, I think. The first is a paper by Janney et al., which came out in 2020 in PLOS Medicine, that tracked the rates of UK opioid prescribing from primary care between 2006 and 2017. And I know this is quite a busy figure here in front of you, so I'll do a bit just to unpack it. The first thing to highlight here is the increase in opioid prescribing rates over those years, which increased by over 500%. We can then take that little inset that's surrounded by a dotted line and blow it up a bit just to look at these other opioids. So you've got a 500% plus increase in tramadol. Again, this is from primary care over that time period. A greater than 3,000% increase in oxycodone prescriptions. And part of that 3,000%, while that's a striking number, that 3,000 is so large because the base rates are quite low here in 2006 and increased substantially. Other ones that I didn't calculate the percent increase for, but wanted to highlight here include morphine prescription rates, which is in the dark blue bar, as well as buprenorphine prescriptions in the darkest of the blue bars down here. Hopefully you can see my cursor. Buprenorphine is a partial opioid agonist, which is often prescribed for the treatment of opioid use disorder. And so in some ways, this is an indirect indicator of increasing opioid-related morbidity, that opioid-related problems seem to be on the increase, as indicated by an increase in the prescription of a medication used to treat opioid use disorder. European-wide, it seems that there are more opioids being prescribed as well. And these data are harder to make sense of because of the differences across the various countries in tracking opioid prescription rates. But this was a paper published just a couple of months ago by Winfried Hauser and colleagues in the European Journal of Pain that tracked increases in opioid prescribing across a number of European countries, both Western and Eastern, as well as some countries associated with the Russian Federation. Overall, what they found here was a net increase of about 36% across all of these countries. And you can see here a significant variability in percent increase rates. We've got the United Kingdom here with an almost 200% increase between those years. We've got Gibraltar here with an almost 500% increase. So quite a bit of variability. Some of these large increases, such as Gibraltar, are again because the base rate started quite low. One thing that I wanted to point out here was that the percent increase in the US between 2004 and 2016 was lower than most European countries. And that's because the increase had already happened in the US. So from this, what Hauser and colleagues argued was that there do seem to be more opioids available via prescription across most European countries. So that's net result 1, just more opioids out there. Net result 2 is a simultaneous increase in opioid-related morbidity and mortality. And one can present a number of different data to illustrate this fact. I've only chosen one here, which is maybe the most significant, and that is opioid-related overdose or opioid mortality. These, again, are US data tracking the increase in opioid overdose deaths between 2000 and 2016. And you can pay attention to the green line only, which is the composite figure here, and see that those two have increased at an exponential rate over the past 2 decades. There aren't these kinds of data, to my knowledge, that are UK specific or European specific. But if you're interested in this area, I'll point you in the direction of the 2 papers I just discussed, that Janney et al. And Hauser et al., because they did their best to try and capture some of this information and make the argument that there seems to be increasing rates of opioid-related morbidity and mortality in the UK and European-wide. And even though the rates of increase or the rate of severity is perhaps not as severe as in the US, it nonetheless is a clinically significant issue. So that's the end of part 1, if you will. And part 1 of this, it seems that the data suggests there's more opioids out there generally, and that the increase in opioids out there seems to have co-occurred or maybe preceded increases in opioid-related morbidity and mortality. But of course, it's important for all of us who work in chronic pain to make sure that everyone we talk to about this understands opioid prescribing practices in general are not necessarily opioid prescribing practices in chronic pain, that these are not necessarily the same population of individuals. That if there are problems in opioid prescribing more broadly, that does not necessarily mean that individuals with chronic pain are the ones who are driving this problem. So in 2015, we published the paper that is in front of you now, which was intended to try and bring some clarity in rates of hazardous opioid use, specifically in those with chronic pain who are prescribed an opioid. And if I may, I'll tell you the backstory of this paper because I think it's interesting. Sitting in a laboratory meeting with my PhD students and my undergraduate students, and one of my discussing issues of opioid use in chronic pain in about 2014. And one smart undergraduate student said to me, what is the proportion of individuals with chronic pain who are prescribed an opioid who go on to get themselves into trouble? And I thought, as she asked that question, I thought it was a real teachable moment for her at how science works and the process of science. So in a perhaps rather paternalistic way, I said to her, go look at the literature. This is what we do when we have these questions. We go to the literature and the literature gives us answers. Isn't science and the empirical epistemology a glorious thing? And she said, all right, sure, I'll go do it. And so she went off, and a week or 2 later, she came back and she said, I don't think the literature can answer this. She said, I found these 2 papers, and one of them says it's somewhere between none of them, 0%, and 50%. And that doesn't seem very useful. That we can't go and tell our prescribing colleagues that somewhere between none of the people who they prescribe opioids and half the people who they prescribe opioids to are going to go on and get themselves into trouble. This was a paper by Hosted and Schrogen from Scandinavia, 2007, something like that. It was published, and Martel et al. From the US and low back pain. Both those papers indicated that hazardous opioid use occurs in somewhere between 0 and 50% of individuals who are prescribed opioids for the treatment of chronic pain. And so we thought what we would do is go through the literature with a fine-tooth comb to see if we can bring a bit more clarity to these percentages. And I'm not going to spend a lot of time talking about these data because it's a bit old, but I'll just give you the highlights. We reviewed 38 papers. These were all individuals with chronic pain prescribed opioids for its treatment. We found the range of hazardous opioid use was incredibly broad, larger than 0 to 50%. In fact, it was 0 to 80%. And so what we did is we defined 3 levels of hazardous opioid use to see whether or not that would bring us a little bit more clarity in estimates. The lowest level of severity we called opioid misuse, and we defined that specifically as using opioids in a manner for which they were not prescribed, or not using opioids as prescribed. And we intended this term to be relatively harm neutral. In other words, opioid misuse in this sense did not necessarily indicate harmful use. And this definition in some ways was based on my clinical experience where I see people misuse or not use as prescribed medications in all kinds of ways. They overuse, they underuse, they erratically use, they save for a rainy day, they lend out if someone needs their medication, they borrow if they think they need it. All of these things that many of us do with our prescribed medications that don't necessarily indicate potential for harm. So across studies, as you can see this percentage in front of you, we found that somewhere in the vicinity of 1 out of every 4 to 1 out of every 5 individuals with chronic pain were using opioids in a non-prescribed manner. Our second level of severity we called opioid abuse, and we specifically defined that as using opioids for the purpose of euphoria, getting high, sedation, those kinds of things. And only one of our 38 studies seemed to assess opioid abuse. It was a high quality study by Elliott et al., I think. And that study indicated that 8% of individuals were using opioids to get high or for the purpose of euphoria. And then our most severe level of hazardous opioid use, we called opioid addiction, which we defined as opioid use in a manner that is either harmful or has marked potential for harm. And for this highest level of severity, the papers seem to indicate, the data seem to indicate that that occurred in about 1 out of every 10 individuals, if you will. And let me just note here, you can see our 95% confidence intervals for misuse and addiction, and that just gives a sense of where these data are. So from this exercise that we did in publishing this, we made 2 primary arguments. The first, which has not been highlighted as much as I wish it had, is that the quality of data in this area is not as good as we would have hoped, that this is not necessarily a healthy area. There's significant heterogeneity across studies, and there's a lot of work to be done if we are interested in determining potential for harm from opioids. The second argument we made is that opioid use in and of itself is not necessarily a problem. It seems that a clinically significant minority of individuals with chronic pain are using opioids in a way that is either misuse, that constitutes misuse, or constitutes potential for harm. And if I may, I'll look at my time. I'm just going to go off on a brief tangent because this issue of opioid use is not just something that's happening in adults, but it also seems to be happening in adolescents. And the data in adolescents is a lot less developed than the data in adults. And so it's going to take a bit more work to understand it. So I'll just show you one paper here that was published by a former PhD student of mine as her doctoral dissertation, Melissa Pielek, who is going to be a superstar someday. She's currently on faculty at Brown University. In this study, what Melissa was interested in examining was whether or not prescribing rates had increased in adolescents, as we've seen in adults, and specifically whether or not any increases that were detected were associated with increases in opioid-related morbidity and mortality. She did this in a single healthcare system. It's the University of New Mexico healthcare system in New Mexico in the US. And she did it in that hospital for a few reasons. The first is that we had access to the electronic healthcare records. So that's the easy reason. But the second was that that hospital system in New Mexico is the only level 1 trauma center, and it's the only hospital in the state that offers specialized pain care for adults or adolescents. So we thought that that would be a fairly reasonable indicator of what was happening more statewide. The other thing that I'll note here is that New Mexico tends to be at the top of the list when it comes to indicators of opioid-related morbidity and mortality across the US. So it was a reasonable place to do it. And I won't take a long time talking about her data. I'll show you what happened with opioid prescribing rates between 2005 and 2016. And that's indicated here by the overarching bar that opioid prescribing rates increased substantially between 2005 and 2008, reaching their peak in 2008. Representing a 200% increase. They then decreased between 2008 and 2016 by a small amount. In 2016, they remained approximately 100% greater than they were in 2005. The bars down here indicate the proportion of individuals who received a single opioid prescription during that time, and the white bars are individuals who received repeat opioid prescriptions. So you can see here that the majority of prescribing was a single prescription of opioids. Presumably for something like an acute injury or discharge medications post-surgery, and somewhere between 15 and 25% per year was a repeat opioid prescription. So Similar thing happening, at least in this sample of young people, and this was about 60,000 prescriptions overall. So it was a big old sample that represented an adequate amount of suffering from illicit illicit for PhD, because that's often the marker that we go by. When we looked at indicators of morbidity and mortality from the electronic healthcare record, we were able to extract 3 indicators of morbidity and mortality. The first was mortality, and I'll note here that this was all-cause mortality. We couldn't extract from the records opioid overdose deaths specifically. The second was the prescription of a medication for opioid use disorder, so buprenorphine, Suboxone, methadone. And the third were rates of overdose. The other thing that I'll note here is that this is the proportion of individuals, and it's or the percentage of individuals each year who experience one of these. And you'll note from here that the base rates were quite low. The highest one was 1.5%. So here's what those data look like. In the bars, we have overall mortality. That represents between 2005 and 2016 an increase of over 2,200%. And you can see the base rates here are again playing a role, that the base rates started low and remained low. But by 2016, one more young person was dying per year, and they had an opioid prescription. Increase in medication-assisted therapy prescriptions was 1,400%. Increase in overdose was also 1,400%. So this is a tricky one to make sense of, because the base rates are low, but the increases are remarkable. And these seem to coincide with what we're seeing in an adult population as well. More opioids on the street, increases in indicators of opioid-related morbidity and mortality. And we should take all of this, of course, with a grain of salt. These are retrospective chart review kind of data. But this issue does not appear to be happening in adults only. All right, and all of this so far hopefully indicates the following: more opioids on the street, more indicators of opioid-related morbidity and mortality, and that in chronic pain, it seems to be a clinically significant minority of individuals who are using opioids in an inappropriate or harmful manner. And I would say these 3 statements contribute to a very pragmatic issue for us as healthcare providers. And the first is well known. The first is that, if anything, we know that opioids haven't decreased the problem of chronic pain. It remains a prevalent, highly common healthcare condition for adults in the developed and undeveloped world, with a number of large-scale epidemiological studies indicating somewhere in the vicinity of 1 out of every 4 to 1 out of every 5 adults experiencing chronic pain, and that these numbers, the prevalence seems to be, if anything, higher in young people in adolescence. We also know that hazardous substance use, including opioids, is either on the rise in our population or perhaps just more in our awareness. And as Jeremy noted at the beginning of this talk in introducing me, we've done a little bit of work in alcohol and chronic pain. We've done a little bit of work in benzodiazepine use in chronic pain. And if anything, I would think that alcohol-related problems have been here all along throughout my whole career. And it's just now, within the past few years, that I'm saying maybe problematic alcohol use is causing problems for individuals. And so for those of us who are interested in treatment, it is likely that at least a proportion of our patients will be experiencing 2 comorbid conditions, some kind of hazardous substance use, opioid use disorder in this case maybe, or opioid misuse, as well as chronic pain. And there is a need for coordinated integrated treatment. And I'm a clinical psychologist by training, and so I default to behavioral treatments when I think about what we ought to do about it. And I would say that the behavioral treatments offer a perfect place to test out the feasibility and efficacy of integrated treatments, because our behavioral methods are complementary, whether or not we're treating a substance use disorder or something like chronic pain-related interference. And so I'm just going to show you the findings of a preliminary study where we sought to do this, to offer this integrated treatment. And then again, I'll tell you about some of the next steps we're taking now. The clinical pilot study that I'm going to describe for you in just a moment here was done in veterans who were being treated in the US Veterans Healthcare Administration. One of the reasons why we selected veterans hospitals to do this in is because, if anything, the problems of chronic pain and problematic opioid use in US military veterans is even more pronounced than it is in the general population. So studies suggest up to 2/3 of veterans have chronic pain. Some older data suggest up to 2/3 of these are prescribed opioids for the treatments of chronic pain, and up to half of those who are prescribed opioids are prescribed doses that are well in excess of recommended maximum doses these days. In addition to that, in US veterans, a diagnosis of chronic pain doubles the risk of any substance use disorder diagnosis, and an opioid prescription is an independent predictor of the experience of an adverse event or a serious adverse event, even after controlling for other known risk factors. So this seemed, in some ways, a perfect place for us to test out the potential feasibility of an integrated treatment such as this. Our overarching aim was just to determine whether or not such an intervention was feasible and whether or not it had initial indications of effectiveness or efficacy. The two treatments that we integrated here were acceptance and commitment therapy for the treatment of chronic pain, and something called mindfulness-based relapse prevention for the treatment of opioid misuse. And I'll describe these two treatments and why we integrated them in the next slide. But for now, I'll just say we did this integration because we had local expertise in these two areas, because both of these treatments have empirical evidence for chronic pain and substance use respectively. We thought that the messaging in them, or the treatment approach, was complementary enough that we could integrate them fairly seamlessly. We recruited veterans with chronic pain, as well as evidence of some kind of hazardous opioid use, as indicated by score on a self-report measure that was in excess of the established cutoff. The measure here is the CALM, or the current opioid misuse measure, and or a diagnosis of opioid use disorder from a structured clinical interview. In terms of those two treatments, in terms of those two kinds of treatments, here are the details on the intervention arm. This was a psychology-only intervention, which consisted of 12 weekly 90-minute group-based treatments. The ACT arm of this was, as is indicated by your screen here. ACT for chronic pain is rated by the Division of Clinical Psychology of the American Psychological Association as an intervention with strong empirical support. This is the highest grading possible, so the evidence base underscoring ACT for chronic pain is reasonably robust. In a nutshell, ACT for chronic pain seeks to help individuals with chronic pain identify meaningful areas of their life that have been adversely impacted by the experience of pain. It teaches them methods to enhance willingness to have pain in the service of these meaningful areas. And it also teaches them present-focused awareness and mindfulness kinds of skills to help them identify opportunities to engage in these meaningful actions. So what underscores ACT for chronic pain is this real cornerstone of engagement in meaningful, valued activities. Mindfulness-based relapse prevention is an evidence-based treatment for, as an add-on for substance use disorders. Add-on meaning that once the substance use has been brought into some kind of control or is no longer problematic, MBRP has evidence as an add-on to help sustain that abstinence or that non-harmful use. MBRP is intended to help individuals deal effectively with cues to use, as well as with cravings. And as the title would suggest, it's a mindfulness-based intervention. So it also seeks to cultivate patterns of non-judgmental, accepting attitudes towards oneself, towards things like guilt and shame and cues for using and craving and all of these things. So we thought that these two interventions were compatible enough that we could combine them into a single treatment, and that they should, theoretically, both decrease pain-related interference and hazardous opioid use. So half of the individuals who were recruited were randomized to the active intervention condition. All individuals who were randomized in the study received standard care, which in this case was specialty care from a physician or medic at a purpose-built co-occurring disorders clinic. That was, the co-occurring disorders were opioid use and chronic pain. So this was quite specialist, and I would argue quite high-level physician-directed care. Here's the overall trial design. This was a simple 2-arm study where individuals were randomized to one of the 2 treatment arms. I'm going to talk to you today just about our primary outcomes assessment, where we looked at outcomes across our 2 primary measures at 6-month follow-up in comparison to baseline. Our first primary measure was the aforementioned CALM. The current opioid misuse measure is intended to assess risk for opioid misuse over the past 30 days. And it's a combination of items that ask explicitly about opioid misuse, such as the one that's in front of you now, as well as the experience of emotional instability or anger or other kinds of emotional experiences that sometimes have been implicated in potential for hazardous opioid use. CALM has reasonably good sensitivity and specificity for hazardous opioid use. Our second primary outcome measure was the PROMIS pain interference measure from the National Institutes of Health, the 8A version, if you know it. The PROMIS pain interference scales are really nice, concise, item response theory developed measures to assess pain interference. And in this case, it's pain interference over the past 7 days across a variety of areas of functioning, 2 of which are on your screen before you. So what we hypothesized, of course, is that the intervention group would experience decreases across these 2 measures that were in excess of changes that were observed in the control condition. Overall study flow is here in front of you. This was a clinical pilot study, so we intended recruitment to be fairly low because we were just looking at feasibility of recruitment, retention, and the treatment approach. So you'll see here at the top, we had 85 individuals completed phone screening. About half of those were formally assessed for eligibility. About 80% of those were randomized. About 80% of the individuals who were randomized began the allocated treatment. And about 80% of those who began treatment provided follow-up data at 6 months. And we'll talk a bit more about what these feasibility indicators mean in just a moment. But our primary analyses here were quite small. 12 individuals in one group and 10 in another. In terms of participant characteristics, there weren't really any surprises here from a standard chronic pain population, with the exception of the predominance of the male gender. And this is an artifact of doing a study in the US Veterans Healthcare Administration system, which is overwhelmingly male. Generally, average age was in the middling ages. New Mexico is quite an ethnically diverse state, and you can see that represented in our ethnic breakdown here. 50% non-Hispanic white, 25% Latino, Latina, about 20% Native American. On average, educational achievements was equivalent of completion of some university. Relationship status was fairly evenly distributed across the 3 categories you see in front of you here of married, single, and divorced or separated. Quite prolonged pain durations, quite diverse and mixed pain locations, pain experiences, significant receipt, of compensation for pain, including Social Security, disability, as well as service connection, which in this context here in the UK deserves a little bit of explanation. A service connection in the VA system is a disability-related connection that is directly attributed to an injury or some event that occurred while one was in active military service. And it indicates, and it has financial compensation attached to it. So a lot of compensation here. In terms of feasibility outcomes, I've already talked about these a bit. About half of individuals who were phone screened went through formal screening. 80% of those who were formally assessed were randomized. 80% of those started treatment. 80% of those who started treatment provided follow-up data. So these are reasonably strong indicators about the feasibility of this integrated treatment. When we examined attendance at the intervention arm sessions, only in those 15 individuals who were randomized to the intervention arm, again, the feasibility indicators here seem to be reasonably supportive. 80% overall session attendance, and almost 90% of individuals attended at least 3/4 of the sessions, which we defined as treatment completion. Okay, so go on to the analyses here and keep an eye on time. We analyzed the 2 groups for any baseline differences, and none were indicated for demographic or pain-related characteristics. with one interesting exception, which was baseline opioid dose that was prescribed. And in what is a potentially interesting failure of randomization, the individuals who were randomized to the intervention condition had opioid doses that were on average twice that of the individuals assigned to the control condition. So if anything, one could maybe argue that the treatment group here was perhaps a little bit more complex, at least as indicated by higher opioid dose on average. So analyses proceeded with an analysis of covariance where we controlled for baseline opioid dose just to ensure we were controlling for any impact they may have on outcomes. So here are our primary outcomes. For pain interference, on the y-axis, you see the estimated marginal mean. So this is the mean after controlling for baseline opioid dose. Along the x-axis, you'll see our pre-treatment and 6-month follow-up values in just a moment here. The blue line, the treatment group, the yellow line, the treatment as usual group. And you can see here that things moved in the hypothesized direction. There was a statistically significant group by time interaction in favor of the intervention group. The indicator of effect size here, partial eta squared, was medium to large in favor of the intervention group. In plain English, what that means is that the intervention group reported less pain interference at 6-month follow-up than did the treatment as usual group. Similar finding for the CALM, again, a statistically significant group by time interaction, this time a medium effect size. Opioid misuse decreased in the intervention group at a rate that was higher or more substantial than the decrease in the treatment as usual group. Another thing that we did with the CALM here was we evaluated the proportion of individuals in each group who remained at risk on that, using that CALM threshold, the cut score. All individuals began above that at-risk threshold. Sorry for the barking dogs in the background. They don't know it's still work time, apparently. In the intervention group, about half of the individuals remained at risk at 6-month follow-up, whereas 90% of the individuals in that physician-directed care remained at risk of opioid misuse. About half moved to the not at risk group, and only 10% did in the treatment as usual group. So this is another perhaps more qualitative indicator of what treatment did here, that about half the individuals moved down to not at risk. I also want to show you one more analysis here, which was opioid dose. And you'll remember that the individuals in the treatment group started at an opioid dose that was a bit higher than the individuals in the control condition. This time, there was no significant group by time interaction. There was a main effective time where both groups had opioid dose that decreased at 6-month follow-up in comparison to baseline. So just a few final thoughts here to hopefully bring some of this together. That's with respect to this integrated intervention, it seems possible to develop a treatment protocol, and it seemed possible to both recruit and retain people in the trial. The reason why there's a question mark at the recruit, after recruit, is that this was quite a difficult trial to recruit to. And it turns out that individuals with chronic pain who are told your healthcare providers are worried about your opioids, do you want to come talk to a psychologist about it, are not lining up at the doors saying, yes, that's exactly what I want to do. In fact, sometimes they need to be talked into it a little bit. So this was a difficult trial to recruit from. And what we've done in the follow-up is really try and fine-tune some of that recruitment to try and enhance the reasons why individuals are being asked to take part in the trial. Treatment seemed feasible, reasonable outcomes here. There's time for just a last brief divergence into the opioid issue. I think what the data say at this point in time is that opioids in and of themselves are not necessarily a problem. Now, the data suggests they're not necessarily effective, but that's a different line of work. They're not necessarily a problem. In fact, what the evidence suggests is that it's how people use their opioids that is the most robust predictor of trouble. If individuals are using opioids for sedation, for emotional control, for numbing out, for achieving oblivion, these kinds of things, that pattern of use seems to be a significant marker of trouble, a significant marker of opioid-related morbidity, excuse me. And that is just a little bit of a chance just to talk here about a radical behavioral approach to understanding behavior. And I won't take any more time to do that than show you a picture of B.F. Skinner and then move swiftly along. But this is an issue I think that all prescribing bodies could benefit from understanding. Opioid prescription in and of itself doesn't seem to be a problem. It's how those opioids are used and the purposes that they are being used for that seems to indicate the potential for trouble. And of course, the data that I just showed you are preliminary small sample and require a fully powered follow-up, which we are doing right now. This is a study funded by the National Institute of Drug Abuse in the US, and we are running it at 3 sites, 3 Veterans Healthcare Administration sites in the Western US, Puget Sound up near Seattle, the San Francisco Bay Area, and then again in Albuquerque. All of this text in front of you is just to say we're running the same study again, except this time we are recruiting veterans on buprenorphine. So these are veterans with a diagnosis of opioid use disorder. And that we're also seeking to examine treatment mechanism kinds of data this time to see whether or not the purported treatment mechanisms have any statistically reliable relation to treatment outcome. We are also running a telehealth pilot study just because of COVID to see whether or not that seems feasible as well. Last few things to do are just to acknowledge the student therapists in this pilot study, my fantastic PhD students who are pictured here in the wilds of New Mexico on a lab retreat, as well as the collaborators on this project, the trial team for the larger trial, which is indeed a larger trial team. As far as I can tell, there's 8 million people who have a role in this study. And then just to say once more, Jeremy, team at Bath, thank you so much for this invitation. I want to show you the requisite beautiful picture of our main university building here at Queen's University in Belfast. It's a fantastic campus if you ever have the chance to visit. And then I think we have a little bit of time for questions, which I'm happy to answer. And I'm also happy to be contacted by email if any questions occur. So thanks to all of you for your time and for your attention tonight.
Thank you, Kevin. Thank you very, very much. What a beautifully clear and thoughtful talk. That's terrific. And it's very like you to finish on the button exactly when you said you would. So we've had some questions come through the chat. And so there's been some interest, and it would be lovely to hear what you think about these things. So I'd like to kick off with a question that has come from primary care, posed by Robin Horton. You ended rather with the idea that opioid prescription in and of itself may not be a wicked thing. There's a feeling that in primary care in this country, there is a strong government-led push for GPs and primary care practitioners to kind of push their patients to reduce their opioid prescription without there being any particular help, and certainly without there being 12 1.5-hour sessions of highly skilled therapy to help them with it. What's your view about a general top-level government push to reduce opioids in the absence of any other supportive services?
What a great question. A great question, and there are no pitfalls in this question at all. Right there, it's an easy one to answer. Here's some thoughts I have on it, and in all seriousness, it's really complicated. I think what we can do as healthcare providers is try and educate our governing bodies on some of these issues, that if we're going to push down opioids, there needs to be an alternative. And please understand, I understand this is far more complex than we do this, and then they say fine. But to continue to help educate them that the removal of one treatment arm is inappropriate and insufficient. The second is to really help them understand that, from my perspective, that behavior change interventions or the behavioral interventions of whatever form they are seem to be a treatment of choice. And I know I have biases in that don't carry with them risk of iatrogenic effect, that the behavioral treatments are appropriate, and that there's a range of intensity from community-based support groups all the way to specialist care at the Bath Center for Pain Services, something like that there's a range here, but that some kind of provision must be put into place if we're going to remove treatment. The last thing that I'll say on this is what we saw in New Mexico, because the US is the US, is as opioid rates went down, heroin use went right up. In New Mexico, which is an epicenter for this, I swear across the street from the VA, the Veterans Hospital, you could see individuals who looked like veterans. And some of this is supposition, who looked like they were walking around, you'd be sedated and really intoxicated, and you got to assume that's heroin. And what the data in the US indicate is that as we've got overdose, hopefully you can see me in the camera, overdose rates going like this in the US, and opioid prescription going like this, but nonetheless, overdose rates continue to go up. And I think those data we can make use of to say, we don't want that to happen here. Of course, it's a different system. Access to heroin and other opioids may be more difficult here, but what we don't want is a transition from opioids over to heroin or opiates. Okay, honestly, last thing I'll say, and Jeremy, I'm sorry, is just to continue, I think for all of us, we have to continue to push this dialogue and not just throw our hands up and not just say it's too much, but to continue to push this dialogue with the people who are making decisions. Throwing the baby out with the bathwater in this case, it has some really significant risk for iatrogenic effect.
Thank you. Now a couple of notes have come through about prescribers, Kevin. Mm-hmm. Could we say something about prescribers? We've seen these rocketing increases. Do we know if it's primary, secondary care? Is it a minority of physicians who are prescribing these things? And is there anything about the prescriber interaction that we could understand or that could do better? I realize that's a topic rather than a set of questions.
Sure. So here's what I understand. These are US-based data, that the predominance of opioid prescription seems to be coming from primary care in the US. And I'm not sure if that's the case in the UK, although that Janney and all article suggests something along those lines. In terms of prescriber interaction, Jeremy, are these questions like, what advice would we give to prescribers?
Yes, that would be a good one to go with. Or do we understand why and how some individuals are doing the majority of the prescribing, if they are?
Yeah, I don't know if it's such a bummer we're not sitting in that old chapel so we could have a dialogue here and not just me waffle on. I don't know that the data at this point are suggesting the historic increases are from a minority of prescribers. I think what the data are saying is that prescribers, primary care prescribers, were doing what they were told to do. They were told to aggressively treat pain, and they were told opioids are the way you do that. They have no risk. And now as we start seeing things curtail, it may be a minority of prescribers that are doing this. And certainly in the US, there were so-called pill mills and really outlying clinics and outlying prescribers who were engaging in aberrant prescribing practices. I wish I had a simple set of advice for prescribers who are interacting with people that they are taking off of opioids, but here's some things that I would say. One is, if there are behavioral-based alternatives in your vicinity, I would work to educate yourself on them and to help patients understand this is a viable treatment alternative that doesn't carry with it risk of overdose or risk of withdrawal. Here in Belfast, there are community-based treatment centers, as an example, and those community-based treatment centers offer a low-level, free level of care that is of unknown efficacy, of course, but it's something that will at least help people understand both the issues with medications as well as alternatives. The other thing that I would recommend is even low-level kind of behavioral-based treatment, such as some training and something like motivational interviewing, just to have the conversation, if you have the time, can sometimes be really useful, even if it's in a 7-minute GP visit. And the evidence in substance use disorders treatment, like alcohol use disorders specifically, has indicated that primary care providers can have effective interactions even in the seconds that you sometimes have to talk to people.
Brilliant, thank you. So one question came through around the type of opioid, and this is related to oral versus transdermal and on what people feel relaxed or worried about. There's been a sense from the questioner there that people have begun to appropriately worry about oral opioids, but perhaps with something like fentanyl patches, they are more relaxed or don't realize the whacking great morphine equivalent doses that can come from that, and people have thus taken it a little bit less seriously. Have you come across any sense of that?
Yes. I don't have a better answer than just yes. I agree. And some of the physicians I work for now just talk about how some of this old idea was that you needed 24-hour continuous pain coverage and then the breakthrough dosing, and how the evidence just isn't backing that up anymore. And if I'm making anybody upset or angry, I'm sorry. It's such a complicated area, this, but what we know now about the effectiveness of opioids, regardless of whether or not they're oral or transdermal, or regardless of the route of administration, is that they don't seem to be associated with reliable decreases in pain intensity in comparison to other non-opioid alternatives. There's a great paper by Aaron Krebs and colleagues published 2018 or something like that, where they followed people out for a year, I think, and that's essentially what they found. Non-opioid alternatives work no worse than opioids, and that opioids were associated with increased incidence of adverse events, unsurprisingly. So at least we know that. And one of the old, sorry, Jeremy, one last thing. One of the old papers of Roger Chow et al. Indicated that the most, I may be misstating the data here, so everybody take this with a grain of salt. The medication with the best evidence for relief of low back pain, paracetamol. Crazy, paracetamol.
Yeah.
2 pence a dose or whatever it is.
Okay, well, I think we can allow ourselves time for one more, and I'm sorry that means that there'll be some questions in the queue that don't get it, but we can always email Kevin afterwards. In the picture of those horrible increasing graphs of overdoses and deaths, is there any sense of the role of polypharmacy? Is there any sense that, yeah, it's written, opioid is written on the tin, but that benzodiazepines, I think I've often seen as a multiplier, or alcohol or anything else. Is there any sense of what's going with the opioid, which is driving death and morbidity?
Yep. I don't have these data in my head, but they're out there, like the proportions, but there's some toxicology data that have been published indicating what else is on board when people are having overdose deaths. And unsurprisingly, the presence of 2 or more central nervous system depressants is a significant risk factor for fatal overdose or for overdose incident. So co-prescribing of benzos is a real risk. And then again, one that I think has been under-detected by all of us for a long time is alcohol use. And in another set of data that we have analyzed and have since replicated, which is a paper under review right now, we looked at a risk of opioid misuse and risk of alcohol misuse in opioid prescribed individuals with chronic pain. And fully a third across 2 entirely distinct samples, a third of individuals flagged up as being at risk for opioid misuse and alcohol misuse. And that third of individuals kind of scares the pants off of me, that those are individuals who are using both central nervous system depressants in a really risky way. And I think there's a lot of work that we could do as providers on legal use, on use of legal substances, let alone the prescribed substances.
All right. Thank you, Kevin.
Thanks, Jeremy.
And thank you so much. We've reached 5 o'clock. We should probably bring it to a close. We unfortunately just have to have a virtual round of applause like here. And we unfortunately can't take you out for the traditional speaker's pint, which is a shame. But nonetheless, we've been really, really grateful for this talk and for your thoughtful comments afterwards.
Thank you all.
So just for everybody else, we have recorded this. We will put it up as a relatively private video on YouTube for a month. So there'll be a link. So if you know anybody who missed it, who desperately wanted to see it, you'll be able to give them the link for the next 4 weeks or so. And anybody who missed the talk will be able to see it. We will keep going. Pain Forum will carry on early in 2022. Do follow us on Twitter at BCPS Bath. That's where a lot of it will come out, or keep an eye on the website. And I'll send out an email via Eventbrite, which has some of these details on it. So thank you all for coming, and thank you very much, Professor Vowles. And we will draw today to a close.
Thanks, Jeremy. Thanks all. Bye-bye.